Before we understand hyponatremia, we need to understand why sodium is important in the body. Sodium is required mainly for three functions: for nerve conductions, for muscle transmission and muscle impulse transmission, and also for volume distribution in the body, since it's the most osmotically active agent in the body. So whenever there is hyponatremia, whenever sodium is low, the symptoms are related to these three things. You may get fatigue because of the muscle weaknesses. You may get headache, somnolence, dysarthria due to nerve impulse transmission disorders, and also brain swells up because of redistribution of fluid in the cells because of hyponatremia, and you may get seizures, etc. To need to know the cause of hyponatremia, the first thing you need to measure is plasma osmolality. Since sodium is the most osmotically active agent in the body, when it goes down, the plasma osmolality should go down with it. But when it doesn't happen, there has to be some other factor to it. There are three types of hyponatremias, and based upon this. So there is hyperosmolar hyponatremia, where plasma osmolality goes up instead of going down. There is normoosmolar hyponatremia, where the plasma osmolality remains normal. And there is true hyponatremia, which is hypoosmolar hyponatremia. So coming to hyperosmolar hyponatremia first. So plasma osmolality should go down, but it's increasing here. So there has to be some other osmotically active agent present in the body, which is more osmotically active than sodium. Glycerol and mannitol are the two most common offenders which are present in the blood, and they cause hyperosmolar hyponatremia most of the time. Coming to normoosmolar hyponatremia, here some other osmotically active agent is present which pulls in the water, and it causes dilutional effect on sodium. Usually in presence of diabetes, glucose becomes osmotically active agent. Same in the case of other hypertriglyceridemia, paraproteinemia, lipoprotein X disorders. Now coming to true hyponatremias, the hypoosmolar hyponatremia. Because sodium is low, plasma osmolality is also low. To figure these out, you need to know the ADH activity. For ADH activity, you need to measure if ADH is working on the nephrons and causing, water, is reabsorbing the water or not. So for that, you need to check urine specific gravity, and the last two digit in the urine specific gravity, urine specific gravity is usually expressed in 1.010 or 1.020 or 1.030. So the last two digit, let's say 20, you multiply it by 30. So that is your urine osmolality. If the urine osmolality is low, less than 100, it's usually in the case either there is ADH is suppressed, like in the cases of primary polydipsia, or there is low total salt intake, like in tea and toast syndrome or Beer-Pottomania. So when urine osmolality is more than 100, that means the ADH activity is normal. So the next thing we need to do is to measure urinary sodium. Urinary sodium tells us about the RAS activity, renin-angiotensin-aldosterone system activity, specifically aldosterone activity. So if urinary sodium is low, less than 30, that means RAS is active. Aldosterone is working and it's causing reabsorption of sodium. So excessive sodium is not getting excreted in the urine. RAS is activated in two scenarios. Either there is low blood volume, like in cases of hypotension, hypovolemia, dehydration, or in the cases where dilutional hyponatremia happen, but the total blood volume is higher, like in CHF, cirrhosis, or nephrotic syndrome. Coming to the final category where urinary sodium is high, more than 30 milliequivalent per liter. Here, conditions like SIADH, where fractional excretion of uric acid will be high, cerebral salt wasting, where fractional excretion of uric acid will be low, or hypoaldosteronism or cortisol deficiency, or renal salt wasting, or diuretics like thiazide diuretics, where again uric acid will be high, are seen.